Thank you very much, Nizam. Just to follow on from the Dean's which I enjoyed greatly, communication is very straightforward with paediatric anaesthetists and surgeons because we just do as we're told. We know it's true. Okay, so I'm going to hopefully talk to you today about when is it appropriate to decline a deceased donor kidney. And when Jelena gave me the title of this talk, I was very, very happy because I thought this has to be the easiest talk that I'm ever going to give because the answer should be very straightforward when the risks outweigh the benefits. But then I made the fatal error of actually thinking a bit more, which is something that I try and avoid as much as possible. And then I thought, okay, how do we actually assess donor or organ risk? How good are we at doing it? How do we assess the benefits of transplantation? When will the next offer come along? Will the next offer be any better? And at that point, I was very unhappy because I realized that this is an almost impossible question to answer. So I'm going to get my excuses in very, very early before Nizam and Nikos start giving me a hard time. Okay, so this is my attempt. I think the important thing is to set the baseline here. So what are the outcomes in pediatric renal replacement therapy? And where does transplantation, and more importantly, deceased donor kidney transplantation fit within that scheme? How can we assess quality of a deceased donor kidney and the risks inherent in transplantation? How good are our organ utilization decisions? And Steve, don't worry, I'm going to reference your paper. It's okay. There are a few other issues that we need to discuss and think about along the way. And I'm going to try and give you a very broad brushstroke, some frameworks that hopefully will help you answer some of these really tough issues that we are often faced with at 3 in the morning. And I think they are very, very tough, and I think we do need support in making these decisions. Okay, so what are the outcomes in pediatric renal replacement therapy? This is based on UK data. All transplant surgeons are aware when they're dealing with adults that, of course, there is a survival benefit with kidney transplantation. We take that for granted. In kids, the numbers are much smaller. We're very lucky in that it's exceptionally rare to see a child die on dialysis or post-transplant, but it does happen. So for me, it was very interesting to come across this data from the UK Renal Registry. If you look at the hazard ratio of death of a child on dialysis versus transplantation, then that is very, very humbling, that number. So that's something that really caught my eye and made me think very deeply about the background risks that our children and their parents have to deal with. You'll also notice the age difference there, and the younger the child, again, the higher risk of death. And I think that's something to also take into account when we're taking the offers at 2 or 3 in the morning. What about the graft survival if we do say yes to an organ? What happens post-transplant? And again, thanks, Steve, for your hard work here. Much appreciated. And this, again, is UK data looking at 3-year graft survival outcomes. You will see that live donor kidney transplant outcomes are excellent, just over 90%, still functioning at the end of 3 years. DBD donors, which are by far the highest proportion of donor types that we implant into our pediatric population. The results are not quite as good, but still very, very good. Maybe too good. Maybe we're saying no to organs that, in fact, we could implant. That's something we'll come back to later. So the meat of the talk now, how do we really assess deceased donor kidney quality? What I'd like to do is to try and give you an approach to this. And the way that I think about these offers is to try and think of the different time courses and the different outcomes that might be relevant at different times. First thing I think we should think about is short-term graft function. In other words, the risks of delayed graft function and primary non-function. Let's start with delayed graft function. We know, first of all, that the risk of delayed graft function is going to be much higher in a deceased donor kidney, probably in the region of 10 to 20% for our pediatric recipients from a DBD donor. A DCD donor is going to have at least twice that rate, but as I've already said, the rate of DCD kidney transplantation in the UK is very low for children. Probably the other major risk factor that we have to think about is donor acute kidney injury. And this is a very good piece of work from the Oxford group and Kat Boffa. This is primarily focused on adult recipients, but I think the fundamental issues here are still relevant for pediatric recipients. And what they did is they defined different donors by their AKIN network grading. So that's AKIN 1 through to 3. You can see the criteria up there on the left-hand side. Then they looked at graft outcome, and I focused here really on the rate of delayed graft function versus immediate function. And you can see that for kidneys going into adult patients, actually, even if you take a donor that's got a severe AKI, so AKIN 3, so a creatinine of more than 3 times the upper limit of normal, the delayed graft function rates are still relatively acceptable. Now, I know that in the pediatric population, DGF certainly has its issues, challenging to manage post-transplant, both for the patient, for the nephrologist, and for the parents. But I think it is worthwhile keeping in mind that even those very high AKIN 3 group donors, we shouldn't be declining out of hand. Of more concern, perhaps, is primary non-function, so in other words, a kidney that never works at all. And again, I think Kat Boffa's work has given us a very useful framework here. And what's really interesting to see is if we look at the rate of primary non-function, as donor AKIN 3 gets higher and higher, there seems to be a threshold effect. When you're getting to stage 3, that's when your PNF rates really go up. Personally, I would find it difficult to accept a kidney for a pediatric recipient from an AKIN 3 donor with a PNF rate of 9%, unless there's some very, very pressing issues in that recipient. That's my framework, but I'm just interested to hear your thoughts on that as well. Again, for AKIN 1 and 2, you can see the PNF rates are really the same as basic. Okay, what about long-term graft function? And this is what really worries us. We're trying to get our kids through at least the next 20, hopefully 30 or 40 years. How can we assess donor quality in that regard? A lot of people rely on SCD, ECD. Now, there are a lot of ways to upset me, but if you want to upset me really quickly, please use SCD or ECD. It drives me nuts. I think SCD and ECD is completely obsolete. It's of no help whatsoever, okay? It's taken from an American definition from the mid-90s, which has absolutely no relevance to UK practice, or in fact, probably even American practice now. And it discriminates between good kidneys and bad kidneys. Life's just not that straightforward, okay? There are lots of shades in between. And what we need is some type of risk index which reflects that spectrum of risk. We're very fortunate because there are lots of them out there. So this is the UK KDRI, sorry, this is the US KDRI, I should say. So this is Rao's paper from transplantation in 2009. And you can see it's a very complex equation that they've come up with there. There is an app, although unfortunately it stopped working with the most recent iOS upgrade, which is frustrating. Luckily, I've got Dr. Marks who can do that calculation in his head, so I can always phone him up at 3 in the morning. That's no problem at all. So that does give us more of a graduated scale of kidney donor risk index. But again, that's a US population. Actually, the UK population with UK KDRI, it's a far simpler equation. Almost anyone can do that in their head. But the problem is, do we actually use that on a day-to-day basis? And even though I'm an enthusiast for these type of issues, I never calculate the UK KDRI or the KDRI of donor kidneys that I'm given. Why is that? Well, because actually, most transplant surgeons and most clinicians will have these risk factors in their head anyway. If you look at the risk factors, they're the ones that we worry about. Donor age, hypertension, donor weight to a certain extent. It's got a few other things in there which actually we don't really perhaps take into account, and maybe we should. Number of days that donor spent in hospital, whether the donor has been treated with adrenaline or not. So lots of issues to consider there. And for those of you who are real enthusiasts, they've just come out with a new UK KDRI. That's for the new kidney offering scheme. The interesting thing there is even if you take the worst 25% of kidneys, that's D4, hard to see here, they still have a 5-year graft survival of 80%. So even though these are the worst 25% of kidneys donated in the UK, they still actually have quite good outcomes. Whether or not they're good enough for that 5-year-old or 10-year-old child is actually a slightly different issue. The vast majority of kidneys that we implant into children in the UK would either be what's called D1, so the very best quartile donor risk, or perhaps D2. Interestingly enough, the risk factors that are included there have changed slightly. You can see that donor age is still an important factor, hypertension is still an important factor. Now donor gender and donor EGFR are creeping in. So every time they reanalyze the registry, other factors pop up as becoming more or less important. The other issue that we really worry about is transmission of serious diseases. We're talking about cancer or serious infectious diseases. I'm not talking about CMV or EBV. When it comes to cancer, if we've had a donor who's had a history of cancer, or perhaps they've died of a brain tumor, that is something we really worry about. We worry about it for our adult patients. But for a child, the thought of having to describe or tell the parents of a child that they've got a donor-transmitted disease, I can barely think of the implications of that. That would be very upsetting indeed. How do we categorize those risks? Is there a framework? There is a framework. It's fairly clunky at the moment. It's slightly out of date. These are the SABTO guidance that was put out by the Department of Health, an advisory committee of the Department of Health. That's from 2014. They'll be putting out an aid memoir shortly, which does try and give more information in a briefer setting. And there's a very long list of cancers and estimated risks of transmission from a donor to a recipient. And you can see the categories there. It's fairly complex. And that's both for non-CNS and CNS tumors. And the website's up the top there. That is something that we actually all do use on a fairly frequent basis when we ask these tough questions. And having a risk assessment is very useful. Is it accurate? It's relatively accurate. It's as good as we're going to get. And it does help us make decisions, I think. As far as pediatric patients are concerned, what should we be saying yes or no to? Well, I think it would be very difficult to justify taking a kidney from someone who fits in the high-risk donor category, particularly when we look at the patient survivals after pediatric kidney-only transplantation. And you can see even up to 5 years after a transplant into a pediatric recipient, between 95 to 99 out of 100 of our children are still alive. That's what we want. I think it'd be very difficult to justify implanting an organ in someone who's got a more than 10% risk of transmission, given that if that transmission occurs, there's probably a 50% chance of it being fatal. So I think we're really looking at these categories in terms of donor risk. When it comes to intracerebral tumours, I think we're looking at the category at the bottom there. What about intracranial tumours with an intermediate risk of cancer transmission? There's a question mark there. I think for some recipients, that certainly would be justifiable. For most pediatric recipients, probably not. And the offer that we get most frequently is a young donor, usually in their 20s, who's died of a grade 4 glioma, a glioblastoma, and then we're left with the very difficult decision of whether or not to transplant that. Even though the estimated risks there are between 2 to 6%, they're probably slightly lower, but that's what's written on the national website, and that's what the lawyers will be using. So if something did go wrong there, I think that would be a difficult situation. And that would very much depend on the recipient situation as well. What about those donors who have increased infectious risk but negative serology? Obviously, if they have positive serology for HIV or Hep C, then that's pretty straightforward, at least in the UK. But if they have negative hepatitis B, hepatitis C, or HIV serology, but they have a lifestyle which leads them to have increased infectious risk, then what should we do then? Again, there's no good UK framework for this at the moment, although there's plenty of data from overseas. I'm talking about those donors that might be prisoners, sex workers, men who have sex with men, or intravenous drug users. There is a lot of information out there in the literature, certainly from Canada, which tries to define this problem and give us some data to enable us to do a risk assessment. Apologies, this is a rather wordy and complex slide, and for those of you at the back, it's difficult to see. But in essence, what they do is they look at different categories of increased infectious risk donors, and they ask you the question, are you just doing your test based on ELISA, or are you doing NAT testing as well? And we're very lucky at Guy's because we do have access to 24/7 NAT testing. And then if you have both a negative NAT test and negative ELISA for serology, what is the estimated risk of actually having a false negative there and passing on those diseases? And you can see for HIV, those risks are very, very low indeed, much less than 1 in 1,000. For hepatitis C, the numbers are slightly different. If you have a negative NAT test and a negative ELISA, then your greatest risk is with a commercial sex worker as a donor, and the risks are in the region of 1 in 300. Now, with 1 in 300, of course, even if those diseases are passed on, the vast majority of our patients we can treat successfully with antivirals. I would start to say that for a fairly large proportion of our pediatric population, the risks would be less than the benefits. Benefits would be better than the risks. In other words, I think we should probably think about saying yes to some of these organs. That would be a fairly difficult consent discussion, I think. You would have to do NAT testing in the recipient post-op, and the patient and the parents would have to have an understanding of the implication if NAT testing came back positive in the recipient. I think that is something that we should be thinking about and exploring with our patients, perhaps at the time of listing. There are other ways to define kidney quality, and this is where things get really murky. You can rely on surgeons looking at a kidney and telling you if it looks good or not. I put it in italics because it's in the verge of pseudoscience here, because there's never been any prospective study which actually says if a surgeon looks at a kidney and is worried about it and you implant it, what is the outcome of that organ? No one actually knows this. No one's ever been able to quantify it. Surgeons worry about perfusion defects. They worry about scars. They worry about damage at retrieval, cysts, and patch quality. In essence, you're just going to have to trust your surgeon and hope that they know what they're talking about if they say, look, I don't think this kidney is usable. I don't think it's good enough for this child. A lot of centers, particularly in the States, will do pre-implantation biopsies, and they'll look at the quality of the kidney microscopically, and they will try and quantify that risk. This is an area of interest for me, and at least one other person in the audience who's presented this data recently at the last BTS. I think, and I think a lot of Europeans would agree, that the predictive value of pre-implantation biopsies is highly doubtful. I would be reluctant to say yes or no to a kidney purely on the basis of pre-implantation biopsy alone. I think the predictive value is fairly weak. There are a large number of different scores which can be used to try and correlate with outcome and allow a prediction to be made, but I think we're on fairly shonky ground at that point. So, assessing kidney quality is fraught with complexity and problems, unfortunately. There are a lot of post-transplant outcomes that we're interested in. They're usually interdependent. There are many interacting factors which make it very difficult for us as clinicians to give a definitive answer to our patients about whether we should say yes or no. Even though I've spent a lot of time talking about donor risk indices, the predictive value is relatively weak. The C statistic in the region of 0.6 to 0.65. Tossing a coin is 0.5. Certainty is 1, so 0.65 is only slightly better than tossing a coin. Unfortunately, there is a lack of evidence base for surgical decision-making, and there's a lot of uncertainty about the utility of pre-implantation kidney biopsies. Oh dear. So we all admit that this is a very, very difficult situation, but we have to do our best. How good are we at making these decisions? Well, we know that a lot of donor offers are declined, and this is UK data that looks at offer decline rates between the UK paediatric centres, and a very high proportion of kidneys are declined that actually do go on to be transplanted. And again, thanks, Steve, for this excellent work published by Matko and colleagues from GOS that looked at organs which were declined for paediatric recipients in the UK, and then worked out what happened both to those patients and to those kidneys. And in the interest of time, I'll skip on to the really important thing here. In the UK, if a kidney was declined for a paediatric recipient but was then went on to be transplanted into another paediatric recipient, then the graft survival was only 89% at 1 year. That's not great. Now that actually implies that we're doing a pretty good job at winnowing out the wheat from the chaff in UK paediatric kidney transplantation. Strangely enough, if you implant that kidney into an adult, however, they've got 96% 1-year graft survival. Actually, I also find that reassuring, because I think that means that there is a fundamental difference between a paediatric recipient and an adult recipient, and I think most of the time we are making the right decision. At least the first time the kidney was declined for a paediatric recipient, maybe not the second time. What about if that kidney was declined just for donor-related reasons or for size mismatch? Again, if the kidney was declined and then implanted into a pediatric recipient, the outcomes weren't great. Surprisingly, fantastic results in adults. So we are doing pretty well there, which is great. We worry a lot about the impact of HLA mismatches with donor kidneys. Actually, in the UK, I don't think we need to worry so much because our offering scheme is so rigid that they really only get offered kidneys with a minimal number of mismatches. Recent data from the US, where they have a far more flexible scheme, and they put in kidneys with a much higher number of HLA mismatches. And it's shown that even with improvements with immune suppression over the years, mismatches still have a significant impact in death-sensitive graft survival, even though immune suppression has improved, which is a worry. And more importantly, when those grafts do fail, which they will eventually, then there will be a higher PRA or CRF at graft failure. We often struggle with this question: should we put a child on the list for what we think they will get, a well-matched deceased donor kidney, or should we accept a poorly matched live donor kidney? I think it's fair to say that the Evelina and GOS, we tend to err on the side of a poorly matched live donor kidney. And again, Steve's done good work in this area. But actually, a larger analysis from a bigger cohort would suggest that a worse matched live donor kidney into a pediatric recipient has much worse outcomes than a better matched deceased donor kidney. So perhaps there is scope for us to reassess that, or even better, to use the sharing scheme, which is something that we're lucky to have in the UK, so that our poorly matched live donors can in fact be converted into a better matched live donor kidney. I know we have lots of people from the rest of Europe and hopefully overseas. Everything that I'm saying is predicated in a UK environment. If you work in a country with a much longer time to deceased donor transplantation, then that changes the equation entirely. So you get used to working in one system and making decisions within that, but that may not be relevant to another country. There are lots of issues that we'll need to weigh up, not just on the donor side, but perhaps even more importantly on the recipient side, and that's not something I've really had time to touch on. We should, of course, be thinking about the dialysis access, how well that line has been working, what their prognosis is, and perhaps most importantly, clinicians, the families, and the child's attitude towards risk, because fundamentally this is what this is all about, as well as weighing up some of the issues that I've touched on today. I would ask that you try and distinguish between organ quality and disease transmission issues, because they are very different and we have different strengths and weaknesses as far as the risk assessments that we can do. It helps if you know the literature and your options. You need to spend a lot of time talking to your family and your patients so that they are really prepared for the type of risks that they may be facing and that you may be asking them to face. And when in doubt, always phone a friend. Predictions are difficult. I find particularly about the future. You just have to embrace that. These are tough decisions. We all do our best. Be aware of what's happening locally and nationally. Control what you can control. Have good surgeons who can put those kidneys in quickly and avoid technical problems. And if you can, work within unit norms. Talk to your colleagues. Thank you.